What was the basis behind you coming up with this protocol?
Well, necessity. I was in the hottest outbreak area at that time in the country, maybe even in the world. Had thousands of patients getting sick simultaneously, and it was battlefield medicine. I mean, my office used to see 40 patients. We were seeing 200, 250 patients a day. We were overrun, and there was no laboratories that weren't open. The radiology places weren't open. There was not enough staff. A lot of my staff were getting sick, so it really was like a battlefield. And I realized that we needed to adjust our approach because all that the world was offering humanity was, take some Tylenol, take some fluids, go home. And if you develop shortness of breath, respiratory distress, go to the hospital, get on a ventilator, and die. That was pretty much the paradigm that we had, which I didn't agree with. So I was studying up, on YouTube there's MedCram.
Hmm.
It's a lecture series, and MedCram episode 34 saved the world, because I was looking at it, and the doctor there described the mechanism of zinc and hydroxychloroquine and the ionophore properties of hydroxychloroquine, which basically means it opens a zinc channel and allows for zinc to go from outside the cell to inside the cell. That was the theory. And then I looked how were patients treated in China? How were patients treated in South Korea? They got hit first, and they had actually used hydroxychloroquine and zinc with some success. And then I looked at what Didier Raoult in Marseille was doing, and he was using hydroxychloroquine and azithromycin. But all that was in the lab or in the inpatient setting. I'm strictly an outpatient, primary care doctor, and I was seeing these patients 2-3 days before they were getting critically ill. So it made sense to me that maybe I could intervene at that point and put out the fire when it's small before it gets out of control. And I just kind of combined the data, the approaches, from the Far East with France, modified the dosing a bit to reflect less acutely ill patients in the primary care setting, and just decided to try it. These are drugs that I knew very well. Hydroxychloroquine I've been using for 2 decades for my rheumatological patients, for malaria prophylaxis. So these are drugs that hydroxychloroquine was being given to children, was given to pregnant women, to nursing mothers. It's safer than Motrin.
Right.
So I was very comfortable with it. And azithromycin, everyone knows Z-Pak, right? It's the most common antibiotic probably in the world. And zinc is just a mineral. So there was no fear factor in these drugs because there was nothing. By the way, I'm not claiming that my approach is the best. If something better comes up, okay, let's transition to that. But we don't have anything better yet. Let's do research in parallel with using the best available data and knowledge that we have at this point, real world evidence. The example I like to use is if I'm drowning in the ocean and I see a piece of driftwood, I don't have a clinical trial that shows me that this driftwood is going to work, but I'm going to hold on to it because I have nothing else. Now, I may get a splinter, but I'm not going to die. Use the best available tools that we have now. Let's develop better tools. And if we develop better tools, transition to those.